Good morning everyone. Today my topic is dentin. Now we know all dentin is the mineralized structure of the tooth after enamel. But what is dentin and what are the characteristics and the details we'll learn in this presentation. Now it provides the bulk and general form of the tooth. It determines the shape of the crown and size of the roots. Dentin physically and chemically closely resembles bone. So it is a close resemblance to the bone. It is said to be a living tissue since tubules present in it and contains processes of specialized cells called odontoblasts. So the sensitivity, pain, everything, we all know that is because of the dentin medium. Now what are the physical properties? First we'll go through color. Now in young age it will be light yellow and with advancing age it will grow into darker. Consistency, elastic and resilient. It is harder than bone but softer than enamel. So enamel is the hardest, after that dentin. Dentin's hardness is after enamel. Now coming to the specialized cell called odontoblast. It is a cell of the pulp. It is mesenchymal in origin from the ectomesenchyme. Dental, pulp, dentin are all originated from the dental papilla. Dental lamina gives rise to enamel. Dental papilla will give rise to dentin and pulp. So dental papilla is one thing but the ectomesenchyme. So it is a mesenchymal origin. It lies along the dental papilla adjacent to the inner enamel epithelium. Development, it is initiated by the influence of various signaling molecules produced by inner enamel epithelium. So certain signaling molecules will be there which will be influenced by the inner enamel epithelium, which will give rise to this specialized cells called odontoblasts. Because we all know without the formation of the dentin, without the formation of the odontoblast, the enamel formation won't begin. Now composition. Composition of fully mature dentin is divided into three. One is the inorganic material, which is nothing but 70% of hydroxyapatite. Organic material, its rest 20%, that is 91% collagen. Collagen 1 and 5 mainly comprises. 9% is non-collagen. Then the rest in the non-collagen we will find out phosphoproteins, proteoglycans, GLA proteins, acidic glycoproteins and the other lipids. Now the rest 10% is water. So mainly it is inorganic material, 20% is organic material and the rest 10% is water. Now this is the picturesque view of the dentinal tubules, how it will be. It is made up of tiny fluid-filled tubules through which the sensation is transmitted to the dental. In these tubules only the odontoplastic processes are there. This only transmits our sensations. So the sensitivity reactions, if there is the abrasion of the enamel and the dentin is exposed, is transmitted by none other than this dentinal tubules. Now of course, there is a gentle curve in A shape. Whenever we will draw the diagrams in the histology, we will all draw that A shape. This is nothing but the shape of the dentinal tubules. It starts right angles to the pulpal surface. The first convexity of the screws is directed towards the apex of the tooth. These tubules end perpendicular to the DEJ and CDJ, dentin-enamel junction and cementodentinal junction. Almost straight near the root tip and incisal edges at the cusp. So the cusps and the root tip will be almost straight. Now what will be the dentin thickness? 3 to 10 mm or more will be the dentinal thickness. Now the ratio between the outer and the inner surface of the dentin is about 5:1. There are more tubules per unit area in crown than the root. So in the crown you will find per unit surface area more number of dentinal tubules than the root. See, now we are coming to the terminal branch of the dentinal tubules. We will find here we are seeing the terminal branch of the root tubules. These are closely spaced but have larger diameter opposed to pulp cavity. Tubules more widely spaced in dentin but becomes narrower in diameter as it reaches the dentino-enamel junction. So as it reaches the dentino-enamel junction, it will become narrower. As the dentinal enamel junction dentinal tubules branch, this causes an increased density in the dentinal tubules in cross sections of the dentin in this region. It's just a knowledge that how the terminal branches of the dentinal tubules divide and how the terminal branches will be spaced. Now coming to the types of dentin, first will be the peritubular dentin. By the name suggests, you can understand that it immediately surrounds the dentinal tubules. Peritubular, around the tubules. So it is called peritubular dentin. It is also called intratubular dentin. So outside one dentin, inside one dentinal tubule. So that intratubular dentin also we can tell as peritubular dentin. It is a highly mineralized than intertubular dentin. So it is more mineralized than the intertubular dentin. It is twice as thick in outer dentin than in inner dentin. It is believed that calcified tubule walls has an inner organic lining termed as laminal limitans, which is high in glycosaminoglycans. So it is having one organic lining which is consist of glycosaminoglycans. Coming to the intertubular dentin, that was intratubular or peritubular. This is intertubular. It is located between the zones of the peritubular dentin. One half of its volume is organic matrix, especially collagen fibers. So it is composed half of it composed of collagen fibers. Half of it composed of collagen fibers. The hydroxyapatite crystals formed along the fibers with their long axis parallel to the collagen fibers. Well mineralized, provide tensile strength to dentin. Highly mineralized but retain after decalcification. So after decalcification also this intertubular dentin will retain. But it is having it will provide the tensile strength to the dentin. So mainly its function is to provide tensile strength, and after decalcification also this layer of dentin stays. Now coming to the predentin. It is located adjacent to the pulp tissue. In this histological feature also it has been marked, which is considered as the predentin. We can see that light area is the predentin. The dentinal tubules, then the odontoblastic layer, where we can differentiate. So located adjacent to the pulp tissue, about 2 to 6 micrometer, depending upon the activity of the odontoblasts. It is a first form dentin, but it is not mineralized. So that is why it is light in color. The moment it is getting mineralized, it will be darker. So predentin is the first form dentin and it is unmineralized dentin. The collagen fibers undergo mineralization at the predentin, then predentin becomes dentin and a new layer of predentin forms circumferentially. So it is a cyclical process. The moment it is mineralizing, it is coming under, again one fresh layer of predentin is producing. Now coming to the dentino-enamel junction. Dentino-enamel junction is a complex and critical structure uniting these two dissimilar calcified tissues and acts to prevent propagation of cracks from enamel to dentin. So it is actually helping to prevent any type of cracks, because enamel is a different type of tissue, dentin is totally different, but in between that this is the junction. 3-level structures 25 to 100 micrometers, scallops with their convexities directed towards the dentin and concavities towards the enamel. So the scalloping structure what we will draw in the dentin-enamel junction is nothing but to prevent these two dissimilar tissues from getting cracks or breaks. And this is a picture of tooth where we can see the dentino-enamel junction, dentino-cemental junction. Now coming to the odontoblastic process. It is a cytoplasmic extensions of the odontoblast. Odontoblasts reside at the peripheral pulp at the pulp dentin border, and their processes extends towards the dentinal tubules. The processes are larger near the diameter of the pulp and taper farther in the dentin. The odontoblast cell bodies are approximately 7 micrometer in diameter and 40 micrometer in length. The junctions between them are gap, tight and desmosomal junctions. There is a controversy with the extension of dentinal tubules to the thickness of the human dentin. This is the odontoblastic processes as we are talking about. You can see here The types of dentin, we can see the peritubular, the intertubular, the mantle dentin, the odontoblast, how it is inserting into the pre-dentin and through the odontoblastic processes. Where is the dento-enamel junction? Till the dento-enamel junction is continuing from the pulp, the cell, odontoblastic cell will be the pulp and dentin junction, and then it will go straight into the towards the through the odontoblastic processes till the enamel. Primary dentin. Now, primary dentin is nothing but the first form. Okay. Dentin that is formed prior to eruption of a tooth before root completion, first form. It is classified as orthodentin, the tubular form of dentin lacking of cells found in the all dentate mammal. It's secreted at a relatively high rate, so rate of formation is high. It constitutes major part of dentin in the tooth. It is of generally two types, mantle dentin and circumpulpal dentin. Now coming to the mantle dentin. Is a first formed dentin in the crown underlying the dentin-enamel junction. This zone is soft and provides cushioning effect to the tooth. Outer and the most peripheral part of the primary dentin, made up of larger collagen fibers than are present in the rest of the primary dentin. Now, Von-Kopf fiber are seen in the mantle dentin. It undergoes globular mineralization and are less mineralized than the circumpulpal dentin. So, it is less mineralized, is having collagen fibers which is larger, it is providing cushioning effect. Now coming to the circumpulpal dentin. It forms the remaining primary dentin on bulk of the tooth. One part is formed by the mantle dentin, the first. Second is the circumpulpal dentin, the remaining part. Collagen fibrils are much smaller in diameter and more closely packed together. Slightly more mineral content than in the mantle dentin. When viewed under polarized light, the mantle dentin, it appears red band, which you can see in this image, red band. It can be differentiated from the circumpulpal dentin, that is purple with black dentin and tubules. We can find the differentiation, we can understand this. The mantle dentin, that is the black dentin and tubules is the circumpulpal dentin. Primary dentin over. Now coming to the secondary dentin. It is formed after the root completion. Whatever dentin will form after the root completion is secondary dentin. Before root completion, primary dentin. Narrow band of dentin bordering the pulp. Contains fewer tubules than the primary dentin. There is usually bend in the tubules where primary and secondary dentin meet. Appears in greater amount in the roof and floor of the pulp where it protects the pulp from exposure in the older tip. Now coming to the tertiary dentin. Now tertiary dentin can also call reactive dentin, reparative dentin, irritational dentin, replacement dentin, defense dentin. So many names are there to describe the tertiary dentin. It is nothing but due to various stimuli, noxious stimuli as we call, like how many types of noxious stimuli, like caries, trauma, cavity preparation, all will give rise to a tertiary dentin or pulp dentin border. Okay. Whenever it will form due to any type of noxious stimuli, that is called tertiary dentin. It is just as the defense mechanism or the replacement mechanism. Now coming to the incremental lines. Incremental lines of von Ebener or imbrication lines appear as fine lines or striations in dentin. It run at right angles to the dentinal tubules. These lines reflect the daily rhythmic recurrent deposition of dentin matrix. Rhythmic recurrent deposition only is the incremental lines. The course of the line determines the growth or pattern of the dentin. Contour lines of ON are seen occasionally representing the hypoclassified bands. You can see in this image. Contour lines of ON also demonstrated in the ground section. We can see the lines of the ON. Here it is clearly depicted. Neonatal line. It is seen mainly in the deciduous teeth and the primary first molar. And what is this? Accentuated contour line is seen. Seen in both enamel and dentin, reflects the abrupt changes in the environment that occurs at birth. The moment it is giving birth, the environment totally changes from in utero from outside. That's why this neonatal line is formed due to the sudden change in the environment. Interglobular dentin. This picture also is vividly seen. It is sometimes mineralization begins in small globular areas that fail to fuse into a homogeneous mass. It results in zone of hypermineralization in between these globules. So between these globules, there will stay in a zone of hypermineralization, and that will only cause the interglobular dentin. It forms in the crown of the teeth in circumpulpal dentin just below the mantle dentin. Dentin and tubules pass uninterruptedly through interglobular dentin, depicting the defect in mineralization. Granular layer, or it is called Tomb's granular, the zone adjacent to the cementum appearing granular. It will appear granular. Seen in dry crown section of root, dentin in transmitted light slightly increases in amount from CJ to root apex, which is also a zone of hypomineralization. Higher concentration of calcium and phosphorus will be found in this layer. Now coming to the intratubular nerves. It is an innervation of the nerve. Under that only we will find the nerves. Nerve fibers are shown to accompany 30 to 70% of the odontoblastic processes, and these are referred to as intratubular nerves. These nerves and terminals are found in close association with odontoblastic processes within the tubule. Synapse-like relation between process and nerve fibers were demonstrated. Most of these were myelinated nerve fibers. So most of them will be myelinated. Now few theories of pain transmission, the most important one. There are certain theories. The first theory goes by the name direct neural stimulation. Here they are telling the nerves in dentin is getting stimulated. But what is the drawback in that? The nerves in dentinal tubules are not commonly seen, and even if they are present, they do not extend beyond the inner dentin. Topical application of local anesthetic agent do not abolish the sensitivity. So if it is because of the only nerve, then it will abolish the sensitivity, but it is not happening. So this theory was not accepted, it was discarded eventually. Now coming to the transduction theory. According to this theory, the odontoblastic processes is the primary structure excited by the stimulus, and that the impulse is transmitted to the nerve endings in the inner dentin. In this also the drawback is there, since there is no neural transmitter vesicles in the odontoblastic processes to facilitate the synapse or synaptic speed. Synapse, because there is no areas or no mechanisms in the odontoblastic process there to stimulate this nerve fibers. Then how come this theory is coming into being? So this is also disputed. Now coming to the most accepted theory of the hydrodynamic theory. What it is telling? Various stimuli like heat, cold, air blast, desiccation, mechanical or osmotic pressure affect the fluid movement in the dentinal tubules. The fluid movement, either inward or outward, stimulates the pain mechanism in the tubules by mechanical disturbance of the nerves closely associated with the odontoblast and its processes. Thus, these endings act as mechanoreceptors and are affected by the mechanical displacement of the tubular fluid. So, it has been accepted because of the fluid movement. Now, what are the age changes of dentin? First, we'll come to the vitality of the dentin, how it is changing. Considered a vital tissue since odontoblastic processes are an integral part of dentin. Vitality to be understood to be the capacity of the tissue to react to physiologic and pathologic stimuli. How it is reacting, that only vitality. So for these two above reasons, dentin can be considered as the vital tissue. Dentinogenesis is the process that continues throughout the life. Throughout the life, we will have dentinogenesis. Although after the teeth have erupted and have been functioning for a short time, dentinogenesis slows and further dentin formation is at a slower rate. How it was in the initial stage, the rate won't be same. As age grows, it will be slow. This is secondary dentin, what is found after the root formation. Now, pathologic changes in the dentin in operative procedures causes changes in dentin. They are mainly the teeth tract sclerosis and addition of the reparative dentin which follows. So, as we described earlier, because of this noxious stimuli, any cavity preparation carries the dentin which is formed hereafter, which will be tertiary dentin or the reparative or the replacement dentin. This is a small flowchart of the reparative dentin. where it is depicting how the pathologic process and operative procedures will result in the odontoplastic processes are exposed or cut. If it is surviving, the dentin that is produced is called reactionary or degenerative dentin. If it is dying, the odontoplastic process, migration of the undifferentiated mesenchymal cells from the pulp will occur. That will give rise to new odontoblast, and that will cause the reparative dentin. So either or, it has to produce reparative dentin just as a protective barrier. This is the reparative dentin, this is the reactionary dentin. We can find the differences here, but this is a small pathological image to just support it. Same thing they're telling how the reparative dentin and the reactionary dentin is helping how it is forming from the odontoplastic like cells. Now dead tracts or blind tracts. Areas with empty dentinal tubules. It appear as dark areas in the crown section of the tooth. With time, dead tracts can be completely filled with mineral and will appear white in the crown section called blind tract. Dentin in blind tract is sclerotic dentin. What is the adaptive advantage? It seals off the dentinal tubules to prevent bacteria from entering the pulp. So this is the most important job what the dead tract does. Sclerotic dentin. In presence of irritating stimuli, it deposits apatite crystals in collagen. Now it blocks the tubules. This is a defense reaction and forms the dentinal sclerosis. You will find here in the image how the dentinal sclerosis looks here. Now dentinal fluid. Free fluid occupies 1% of the superficial dentin and 22% of the total value of the deep dentin. Ultrafiltrate, what is actually the dentinal fluid? It is the ultrafiltrate of the blood from capillaries. It contains plasma proteins. It also serves as a vehicle for progress of the bacteria from necrotic pulp to periradicular tissue. Now, what are the developmental defects which affects the dentin? First, we'll come to the dentinogenesis imperfecta. It's a genetic disorder of the tooth development. This condition is inherited in an autosomal dominant pattern as a result of mutations in chromosome 4q21 in the dentin sialophosphoprotein gene, TSPP gene. So, mutation of this gene only will result in this genetic defect. It affects the deciduous as well as the permanent dentition. The shield is classified as type 1, type 2, type 3, but the revised classification is only 2, dentinogenesis imperfecta 1 and dentinogenesis imperfecta 2. Clinical features, it affects the males and females equally. Teeth are blue, grey or amber brown and opalescent. Few days after eruption, teeth may achieve a normal color, following which they become translucent. So this is actually the problem. We get abraded, that amber color will come out. This is a radiographic interpretation. We are seeing how it gets abraded and how the dentin is exposed, and it is complete. Here we are finding where is the dentin. The enamel structure we are finding it. Now what is dentin dysplasia? It's a rare dental anomaly, normal enamel, atypical dentin, abnormal pulp morphology. Now classification according to Whitcup is type 1 radicular and type 2 coronal. Histological features, if you are finding, it is calcified or tubular dentin, amorphous form and cascades of dentin. This is the most histological finding is lava flowing around the boulders, where we are finding an inorganized mass of dentin all throughout the tooth. It is not at all in a proper mineralized state. So it depicts a picture of lava flowing around the boulders. Wherever it is finding the constriction, it is changing its route and again laying down the matrix, but which will give a picture of this, somewhat like this. Now the third problem or the defect we will find is regarding dentin is regional odontoplasia. It is usually seen in the maxillary anteriors. Unusually large pulp chamber with thin layer of enamel and dentin. We can see how thin it is, like translucent. Delay or failure of eruption, irregular in shape. So it is otherwise termed as boosted. We'll see how the large puncture, how translucent the enamel. It is like through and through we can see it. So it got the name as boosted. Histopathological features: reduction in the amount of dentin, widening of the pre-dentin layer, presence of intertubular dentin, irregular tubular pattern dentin. Totally lost the actual dentin pattern mineralization. Hope this small presentation about dentin will help you. Thank you for the patient listening.